So I got cut off at the end when I was talking about prioritizing who would be a good nurse to float to the ER. You know, somebody that has a past and working in the ER and maybe switch, now they want to do OB. I always say in my next life I want to be a NICU nurse when I retire from teaching, because my daughter was in the NICU and I just think that'd be interesting to learn, but you have to live in a big city. And ideally, at this time in today's world, it's probably the safest to live in a big city. Anyway, so you need to also be able to recognize who you would see first as the nurse, what patient. You get 4 patients checked in at once, so you're going to see the shortness of breath patient, or you're going to see the abdominal pain, or somebody that has a cough for 10 days. Obviously, you're going to see the shortness of breath first. Also, patients, or nurses, sorry, you're going to have your emergency nurse specialty certifications. You can get certified as an emergency room nurse. You can get certified as a pediatric emergency room nurse. So those are tests that you can take after you graduate, after you've had some work experience. Next slide. There we go. Emergency nursing principles. We're going to talk about that next. The triage nurse is the gatekeeper. They are the ones that triage patients in an orderly fashion. They sort patients into priority levels of who do we see first. So they're an important role in today's society. The emergency room nurse is an organized system for sortifying or classifying patients into priority levels. In the ER at Hannibal Regional, it's typically an RN that does it, and they are able to make decisions quickly, and they know who needs to be seen first. They can initiate protocols for lab work or diagnostic studies. You may have seen some nurses do some we call them standing orders at Hannibal Regional. So be aware of that. When we classify patients, there's models that we can use to classify patients. Your textbook talks about using models that are emergent, which is life-threatening, patients who have respiratory distress, chest pain, stroke, active hemorrhage, or unstable vital signs. Urgent patients, they need quick treatment but aren't life-threatening. These could be your abdominal pains. They could have a kidney stone, displaced or multiple fractures. So our elderly patients that fall, we don't know if they're on blood thinner or not, so they're probably an urgent. Some soft tissue injuries, patients who maybe have pneumonia. Non-urgent is skin rash, strains and sprains. A simple fracture, say a little kid fell and broke his wrist, maybe jumping on the trampoline. But you probably don't want to leave pediatric patients out in the waiting room either, so they may move to urgent. With the COVID going around, I would say that's an emergent. You wouldn't want that patient waiting in the emergency department, waiting room. Patients with over 101 temp, we want to get them back quickly too. Other models used in today's work and reality is the Emergency Severe Index. This is what we use at Hannibal Regional Hospital. It uses an algorithm and it levels 1 to 5, which is level 1 is urgent and a level 5 is non-urgent. So depending on the number of items you order between labs, radiology exams, medications, consulting respiratory, your analysis kind of falls into its own class. So if they come in with dental pain, they are going to be a level 5. That's not really urgent. We're not going to do anything. If somebody comes in and says, oh my gosh, I know I have a UTI, and all we're going to do is do a urine sample on them, they would be a level 4. As long as they were afebrile, they'd be a level 4. If they had a fever, we might need to investigate further. A level 3 would be your abdominal pains. Because you're probably going to do lab work. You're probably going to do a CAT scan of the belly, get a urine sample. A level 2 would be somebody with chest pain that may or may not be having a heart attack, because you're going to treat them the same. You're going to do the same workup. You're also going to do an EKG, somebody with chest pain, lab work, check a troponin, white blood cells, kidney function, liver function. You're going to put an IV, probably some fluids if they're not having if they're not fluid overload. You're going to do a chest x-ray to make sure they don't have pneumonia. Do a good thorough head-to-toe assessment focusing on the cardiac aspect. A level 1 would be your unconscious patient who is unresponsive and maybe was in a motor vehicle accident. And when we meet over this during class, I have some examples we'll talk about. That the ESI level 1 requires immediate life-saving interventions. So we'll go over this more into detail. And then the Canadian Triage Acuity Scale, that's what they use obviously in Canada. And it's also reliable. It differs a little bit with the scriptures used for triage load. Whatever triage model is used, triage nurses must use a systemic approach, allowing solid clinical decision-making skills and maintaining caring ethic. Nurses we can experience burnout. Disposition. When we discharge patients from the emergency department, they can go different places. They can go to the hospital. They can be transferred to a specialty care unit such as Blessing, or we send a lot of our stroke patients to University of Missouri, Columbia. Most likely, though, our goal is to discharge them home with follow-up care and instructions. Before we discharge them, though, the physician reviews lab works and radiology exams and makes the decision. The nurse does not. The less time they're in the ER, the better, studies have shown. Case management. Case managers give real-time approach. They arrange for the appropriate referrals and follow-ups in the emergency departments. They can review ER census and trends. They identify the primary reasons a patient sought emergency service, such as having lack of primary health care provider, exacerbation of disease process, lack of health education, or lack of financial resources. Not so much in Hannibal do we have we do have a homeless concern, but a lot of patients who are homeless do come visit us in the emergency department because they know we're open 24/7, and that would be one of your vulnerable populations. And with case management, they can look for a safe environment for these homeless. They can also help with domestic violence or elder abuse patients. As the nurse, the key is to health teaching. What can we do to help prevent them from coming back to the ER? We always want to educate about wellness and injury prevention. My favorite question is when patients come in with bike accidents or four-wheeler accidents, they hate me, is, did you have on a helmet? I always make a big deal and celebrate that the child who had the helmet on did. I make a big deal of it, like, that's so smart, you're a great kid, way to listen to mom and dad about wearing your helmet. And then if they don't wear a helmet, I do tell them, if they're kids that aren't like totally freaked out, I tell them that next time if they have an accident, their brain guts might come out of their head. because it's very important for children to wear helmets and we don't have neurological deficits. We also, patients who are smokers, we need to educate on. Now, if you have grandma who's 85 years old and has smoked 60 years, yes, she needs to quit smoking, but she already knows it's bad, so I try not to make a big deal of it. Just say, I know you know, but I have to tell you. Next thing we experience in the ED is the end of life. Death can occur at any time. Sometimes it can be sudden and unexpected, or it can be anticipated. The patient with lung cancer, he's short of breath at home, and he's just so afraid and panicked, so he drives himself to the ER to get assessed. Studies have shown that when we are resuscitating patients, that family presence is accepted now. We usually allow 1 to 2 family members at the bedside when we're doing CPR. It allows for the family to grieve and understand what's going on. If a patient dies before family members arrive, we want to prepare the body in the room for viewing by the family. Sometimes we can't remove everything that's in place, like the the intubation tube and Foley catheter, if for suspected trauma deaths or homicide or abuse cases. We need to leave everything in place until the coroner comes. When we're communicating with these patients, not the patient, the family members during crisis of being with a deceased patient, we need to use simple and concrete words. That, yes, he did die. Don't say he's passed away. You need to say he died. You need to be caring and compassionate. We can offer the social worker, or we can offer the clergy at Hannibal Regional or wherever you may work. I did, when I had a patient pass away when I was working the med-surg floor, the wife had a seizure because she was just so anxious and she had a history of seizures. So they may also be treated in the emergency departments during this time. So, and also as you're the nurse, dealing with death is difficult. So have a plan how you are going to deal with death. Maybe you need to tell the triage nurse after your patient passed away, hey, I need to take a 15-minute walk and I'll be back. Our patients that come see us sometimes are homeless. My favorite homeless patient, his name was Homeless Sam. He passed away a few years ago. He always had a great story to tell when he came in. They know that the ER is open 24 hours a day, and we're required to perform a medical screening, examine all of these patients. We need to know that the ER is a safe place for food, medical care, pain relief, and human interaction. Homeless Sam would always come in because he had horrible COPD. And when the weather changed, we knew he was coming. And when we have homeless patients, we need to understand that they're at risk for TB. We need to not stereotype them. It's their choice. I mean, it may be their choice. It may not be. We need to use standard precautions when assessing them. Trauma nurse principles. When we think of trauma, it means any type of crisis resulting from a heart attack or psychological stress. I want to change that. The general public tends to think that. But among healthcare professions, trauma refers to bodily injury. Injury management is a key component of this. Over 30 million people in the United States visit the ED each year to receive treatment for injuries in 2017. Trauma nursing is a field that encompasses the continuum of care from injury prevention and pre-hospital services to acute care, rehabilitation, and ultimately community reintegration. Trauma centers have their roots in military medicine. And this is when we break out the different trauma centers. Level 1 trauma centers, those are going to be in your large cities. University of Missouri, Columbia, Barnes, I think SLU, and I think Mercy is too, in St. Louis. They're usually located in large teaching hospitals. They provide a full continuum of trauma services for all patients. Conducting research is a requirement for designation. Level 2, they provide care to most injured patients and transport patients if needs exceed resource capabilities. I believe Blessing's a level 2. Level 3, they focus on injury prevention. They stabilize the patient with major injuries and transport the patient if needs exceeds the resource capabilities. Level 4, they're usually located in rural and remote areas. They provide basic trauma, patient stabilization, and ACLS within resource. We're always in level 4, they're going to arrange transport to higher trauma center levels as necessary. When we level 3 trauma centers, that's probably where HRH could fall, but you have to apply for certification to be a level 3. Level 3s have general surgeons and orthopedic surgeons that are immediately available. If critical, you have to transfer to a higher level of care. Trauma systems, they came around from military experience. Trauma centers save lives, but it has to be organized and integrated approach to trauma. They have access to communication technology, timely availability of pre-emergency medical care, rapid transport to get them. Last spring I went to a talk where in Springfield, Missouri, well, I was in St. Louis, but the surgeon was from Springfield, Missouri, and a patient got his hand caught in the auger, which is some farm equipment that has slices going both ways, and his arm was caught. And one story, they were able to save the guy's arm because they were able to transport quickly. The other patient, they were unable to save his arm because it was stuck, and he was also, I believe, 3 hours from Springfield, Missouri at the time. So rapid transport is very important. I think Campbell Regional does a good job. When we have a true trauma, say somebody falls off a 10-foot building, we have EMS. We'll call Marion County Ambulance and put them on standby. And if survival can fly that day, we put them on standby. We also need to start early rehab services. So if they've had a stroke, you want to get them up and moving, but also keep the patient safe. When we think of a trauma, these are important things to know. How did the trauma occur? What was the mechanism of injury? So little Johnny Sue fell off his bike and he comes in complaining of a head injury. What caused the head injury? What happened? So you always want to know that. So most of these can fall into these 4 classes. They can also fall into more. So blunt trauma includes it results from impact forces such as those sustained in a motor vehicle accident, a fall, or an assault. Blast explosion is an exploding bomb can also cause blunt trauma. So when we think of a blast, it's like an exploding bomb. Acceleration, deacceleration forces. These are forces involved in high-speed crashes or falls from a great tall building. My cousin, it's I guess he's my second cousin. He fell from a 10-foot ladder in a garage. He was working on the air conditioning unit. Lost consciousness, got transported an hour. He does have a minor acute memory loss, but It's actually not very bad at all for falling 10 feet off a ladder and hitting his head and passing out. And he lost like 3 of his front teeth, but now they're fake. Penetrating trauma. So, injury from sharp objects and projectiles. Example could be knives, ice picks, bullets. Shrapnel can also produce a penetrating trauma. So when we think of this, we need to think that what was the mechanism of injury? When we think of this, if we think of a gunshot to the abdomen, we need to be quick to think what life-threatening consequence could happen that the trauma team is going to intervene for. It needs to be rapid, quick. Okay, this is an example question. The nurse is caring for a client who was attacked on a rooftop. The client was repeatedly kicked and then shot in the leg, which contributed to a fall from a 5-story building. What make of injury will the nurse document? Well, they experienced blunt trauma. They were kicked, so definitely blunt. Nothing exploded, so no blast. He was shot in the leg, so he penetrated. Also, he had acceleration and deacceleration force. So there is that. Next, we're going to talk about when we're the trauma nurse. Trauma nurses, you can take if you're a trauma nurse, you can take Trauma Nurse Core Competency course. Core course. It's a 2-day course that you can take, and you learn how to assess via using these mnemonics to assess. So, primary intervention is always to have a safe scene. If we're out in the field, if we're in the emergency department, we assume it's safe, but we need to use standard precautions in the ER. We're going to probably, if it's a true trauma, we're going to have our gown, gloves, eye protectant, face mask, surgical cap, and possibly shoe covers if we suspect significant blood loss. So the first thing I think of is your ABCs, and we'll add a couple letters. So airway, we're always going to maintain their airway, and we want them on a non-rebreather mask if the patient's breathing spontaneous. We want to ensure adequate oxygen supply. If there's no lung sounds, we're going to move on to breathing and determine whether our ventilation is effective. We're going to listen to lung sounds. We may need to intubate at this point with an endotracheal tube. Does the patient need CPR in progress if they're not breathing? So when we're doing that, is our CPR effective? And if the patient, we need to make sure they're having lung expansion. And after we intubate this patient, which is later, we need to add an OG tube so their belly can be decompressed. Circulation, C. What's their blood pressure? Are they have an adequate heart rate and overall tissue perfusion? If it's a true trauma, we want our femoral blood pressure to be at least 70 systolic. We also want to achieve good IV access. We need large bore IVs, such as 216 gauge, or possibly a central line can be obtained either femoral, subclavian, or jugular. If we can't get that in, we may need to put in an intraosseous into the bone. We want to give crystalloid solutions, lactated ringers, or normal saline. If they're having lots of blood loss, we need to anticipate the need to give blood, such as red blood cells, fresh frozen plasma, or platelets. However, our priority is always to stop the bleed. D is new to you. well, it's not new because you've been doing it, is disability. What's their neurological status? And we use a cute little mnemonic called AVPU, A-V-P-U. Are they alert? Or do they respond to voice? Or do they respond to pain? Or are they unresponsive? AVPU. We can also use the Glasgow Coma Scale. And the lowest score for a Glasgow Coma Scale is 3, because you rate them like 1 to 5 or 1 to 6 in different areas. And if it's less than 8, you need to intubate. And our last letter we're going to talk about is E. The final component of the primary survey is E, which is exposure. We want to remove all of their clothing. We need to always carefully cut away clothing with scissors. We want to rapidly do this to assess their skin. We don't want to manipulate a limb that could be broken or cause further injury. And if it's a thermal or chemical burn, we need to remove the fabrics to make sure it's not melted to the skin. Also, the clothes could be wet and they could become hypothermic. Also, when we take off the clothes, we want to be extra careful because there could be weapons, drugs, or bullets in there. One time I had to cut off a patient's Carhartt paint, like overall bibs that cost lots of money, and he was yelling, but, you know, he was bleeding internally in his abdomen from a gunshot wound. You also want to get a good temperature when we expose them. If we think they're hypothermic, the best way to get a temperature is a rectal temp. If there's excessive bleeding, you might have to use CABC and start with circulation. Secondary survey. I'm going to go over a couple letters with you to help you. F is full set of vital signs. You're going to do a focus assessment on your adjuncts, and you want to facilitate family presence. G, give comfort measures. H, do a head-to-toe assessment and obtain a history either from the patient or family members. And I is any other interventions and inspect the posterior surfaces. So like I said, if we've intubated the patient, we need to put an OG in or NG and maybe put a temp sensing Foley catheter in if they're hypothermic. So all that. I'm looking at my notes, sorry. Also do diagnostic testing. You want to do your chest x-ray, your lab work. So after this trauma, we're going to have to figure out what we're going to do to him. Is he going to go to the operating room or radiology? Is he having a big heart attack? Does he need admitted to the inpatient unit for observation? And we're going to give him fluids to resuscitate his fluid volume loss. If he's probably at Hannibal Regional Hospital and he's a true trauma, we're going to transfer him to a higher level of care. And then another implementation they talk about is SBIRT, which is screening, brief intervention, and referral to treatment, which the interprofessional trauma team members includes emergency and trauma nurses are educated to assess patients for problems with drinking. So we need to educate our patients on not drinking, which could have caused their trauma. Audience response questions. Which patient will the nurse triage for care first? A 7-year-old with a protruding ulnar fracture? Probably not. But maybe. A 19-year-old with nausea and back pain? I'd probably see the 7-year-old first because it's a pediatric patient. The 43-year-old with weakness and fever and 102-degree fever, or the 54-year-old with upper abdominal pain and shoulder pain and profuse sweating. Well, in today's world, with the COVID or the coronavirus, you would probably see the 43-year-old with weakness and 102-degree fever. Because we don't know if she's been out of the country or traveled anywhere in the United States, such as New York City. But in reality, prior to March 1st or February 1st, whenever it came to America, you would see the patient with an upper abdominal and shoulder pain and profuse sweating because they're most likely having a myocardial infarction. So hopefully on NCLEX, they don't have both of these. So I'm pretty sure they won't now. They're probably making some test changes. So I think I will have it clear and cut on the test that you're not going to have to fight over these two answers. A patient undergoing triage reports dizziness. As the nurse collects assessment information, the patient suddenly becomes unconscious. What is the priority action of the nurse? Well, we're going to go through our A, B, C, and D, and E. So, obtain vital signs. That would probably be part of your circulation. Contact the ED physician. Maybe not right away. Evaluate the patient's level of consciousness. That's neuro, so that's D, disability. Or position, section, and administer oxygen as needed. That would probably be correct. B. D is the answer because that's part of B, which is breathing. So you would first position, section, administer oxygen as needed. I'd probably yell at the physician next. Evaluate the patient's level of consciousness. And then obtain vital signs. Question 3. A female patient is being evaluated for what her husband describes as a fall after tripping over their small dog. Aw, happens all the time. Upon assessment, multiple bruises in various stages of healing are noted around the patient's face, neck, and upper arms. That does not happen all the time. What is the patient's appropriate nursing response? And using your primary survey, you can ask if your emergency department had the forensic nurse examiner to see the patient, because we're going to suspect abuse because of the multiple stages of healing.